And I'll put up the slides again now. So, welcome everyone again. As you know, well, it's the start of a new financial year, and we always plan to share what we have in stock for the year, what we plan to work on for the year, and of course, early diagnosis and innovation. We've been doing a lot of work with primary care. So we have some programs that are continuing, such as the lung cancer screening program, the pancreatic case finding for the 5 PCNs that are already involved in that. We've been undertaking some liver surveillance program in secondary care, and then, of course, there's still the FIT work we'll be continuing with. Some new programs are coming up, such as ColoFit, which is going to be reviewing pathways for managing low-risk symptoms for FIT, and also going to be scoping options to support ColoFit, including feasibility of a proctology clinic in a community setting, which is where primary care will come in, because majority of that work is going to be done also in secondary care with the endoscopy unit. But at some point, there's going to be a lot of interactions with community and primary care settings. Under our primary care program, we still continue working on urgent suspected cancer referral forms and implementing standardized guidance. We have the primary care toolkits, which we started last financial year. So there's still going to be more of that going on, including education, information, and resources that we'll be making available to everyone. There's also going to be targeted education in response to the training needs assessment that was conducted last year. So we'll be bringing out, we'll be letting you know of any targeted topics or tumor sites that we'll be discussing in our education sessions. We have some new projects coming up, such as the health pathway, which Katie will be touching on later on in the meeting. And then there's dental work audit to address head and neck cancers that's coming up with the ICB. For local innovation, there are 2 other new projects that are coming up, which Katie will also be touching on. So that's the self-request chest X-ray and then the coding improvement project. Some of these projects, not some, all of these projects at some point will be coming to you on the next steps on what we plan to do. And then, as usual, it's early diagnosis and innovation. So there's going to be some horizon scanning in terms of innovative programs or projects or pilots that we are going to be undertaking, some of which may include the Horse and inherited genetic condition, or capsule sponge for Barrett's esophagus, and then enhanced health checks. So we have a directive to deliberately include prevention. So a lot of the things we've been looking at in the past has just been early diagnosis and screening, but now in line with the National Cancer Plan and in line with the 10-year plan, we have to put in prevention. And so we started working with directors of public health on initiatives to address prevention, building a relationship with the Genomic Medicine Service Alliance for everything that has to do with genomics and addressing the early diagnosis aspect of it. And then there's the HPV vaccination uptake. You'll hear more about that. We're working on using behavioral science techniques and nudge theory to improve uptake in HPV vaccination and breast screening. Under the screening, we've been working closely for some time, of course, with the Southeast Screening and Immunizations team, and also the Southwest Screening and Immunization team that handles Swindon. And there's, well, I'll say there are projects already taking off some in the pipeline and some that have already started. And then under timely presentation, we continue with our campaigns, including some new campaigns such as the Defend Your Future, which is going to be addressing prostate and lung cancer. And then there's a mobile outreach van that is in the works to go out to selected places. But all that will be updated as they emerge. I don't know if there are any questions regarding the work plan for the year or any comments. Yes, Lily.
Hello. I'm just wondering about the breast screening uptake. I've tried to reach out to the breast screening team quite a lot, and they were meant to send us like a pre-notification list for my PCN, and they've still not done it yet. So we find it quite tricky to sort of contact patients to advise about their breast screening.
Okay. Yes, Gemma. Go ahead, Gemma, please.
Hello, sorry, I was just flicking my camera on. I don't think we've met before, Hayley. Nice to meet you. I'm Gemma Harris. I'm a senior screening and immunisation manager in the Public Health Commissioning team, so the commissioners of the breast screening service. So if you want to drop me a line, I can put my email in the chat. I can link you up with the programme. It may be that you're not due around, but I don't want to make any assumptions on the call. So let me link you up and we can take it from there.
Yeah, that's lovely. I did ask when I first started, and that was sort of 3 years ago. So nothing's ever come of it. So that would be great. Thank you. Yes, please. I'll have a look in the chat for your details.
Oh, I have seen you before. I just realised now I've seen your face. We have chatted before. Yes, happy to be the in between. Yeah.
Okay, lovely. Thank you.
Thank you, Emma, Gemma and Ellie. Any other questions before we move on to the next piece of the agenda and add over to Katie? Yeah, over to you, Katie. Thank you.
Thank you. So the next part of the presentation is just going to cover some potential projects that we're looking at as a Cancer Alliance that could be of interest to different PCNs and practices. So the first one is the high or elevated platelet level pathway. So this is a flag that uses personalised platelet count thresholds to allow GPs to identify potential early cancer signs from routine blood tests that we do all the time within primary care, especially where symptoms are a bit vague or non-specific. Now, this was thought of by the University of Exeter, and they did a retrospective study looking at individuals diagnosed with cancer and then cross-correlated what their platelet levels were early on in that journey, so before they even had a diagnosis of cancer. And they found a really high correlation, which we all know about, of raised platelets and cancer diagnosis. So they came up with the age and sex-specific thresholds for platelet levels. And what they did was attach these to the lab results going back to certain GP practices that were identified as keen to take part in this pilot project. And at that point, when those platelet levels come back, the GPs are then prompted to kind of look at the history of why that patient got in touch in the first place, think, oh, is there something that could be going on that we already know about and actually is under investigation? And then also move through some next steps, which are very logical, and I'm sure lots of GPs do anyway, but it kind of standardizes a process for a PCN kind of level footprint. So some of those were repeat within 6 weeks, and often 50% plus would normalize. If those platelet levels didn't normalize, then they were prompted to consider doing the non-site specific test bundle. Now, obviously, within those tests, if there was a site-specific cause to be found, for example, a raised FIT, then they would go down the colorectal pathway. If no obvious source could be found, then they would refer into the non-site specific pathway. So all the participating practices that have taken part would receive these standardized prompts and then the case finding tools, and their referral processes could be streamlined based on what the results were for that specific patient in front of them. So the University of Exeter has now rolled this pilot process out in about 9 different areas. And as a Cancer Alliance, we're really keen to be part of this and really to speak to practices and PCNs who may be interested in undertaking this piece of work. Now, Steph's going to talk in a bit more detail about the funding of this project. So I don't know whether you're there, Steph, just to come in on that in a bit more detail.
Yeah, so in principle for this project and the other ones that we're just going to talk through, what we would be looking as part of the project development is how best to support PCNs to be able to actually to participate. Now, some of these projects they will be in a test phase, and then we would be looking to scale them. So the opportunity in the test phase, I guess, is to understand the reality of how much things cost and what the considerations are. And that will then help us with, I guess, future scalability in those, I guess, important commissioning conversations. So I don't know, as these projects develop, we'll understand a bit more about potentially how many PCNs could participate in each of the test phases, and then we would be contacted, or well, we'd have a wider conversation and then offer out an expression of interest.
Thank you. That's really helpful, Steph. So what I'll do, I'll move on to the self-request chest X-ray and then the final project. And then at the end, I can take any questions about any of these projects. So the self-request chest X-ray, again, is another project that's been done in other areas. And following some stakeholder engagement, we are hoping that this lung cancer self-request service will be piloted from Q3 in an area of high deprivation and lower than expected for that deprivation level lung cancer referral rates. And eligible patients will be able to self-request a chest X-ray. So the target population for this project, as you can imagine, is symptomatic adults age 40 plus who are not current or former smokers. And it's designed to reach the groups that are not covered by the lung cancer screening program. So within our area, we'd then have two programs of work, the lung cancer screening program, which is asymptomatic individuals, and then we'd have the self-request chest X-ray, which would hopefully be capturing those symptomatic individuals who may be less inclined to go to the GP. So the self-request would be available for those patients meeting the NG12 criteria. So it's a very confined group of patients who are screened robustly at the point of requesting that chest X-ray to see whether they're appropriate or not. So this really builds on the learning from the East Midlands Cancer Alliance, who have successfully piloted this across the University of Leicester kind of trust, and that program of work has been really successful in picking up some symptomatic lung cancer individuals. And then I think the idea would be, if successful, this model may be adopted into neighbouring areas. And it's really interesting because now, as part of 111 services, they are now directing patients to get a self-request chest X-ray. So this is happening in other areas in different forms. And it's just something that we feel that as a Cancer Alliance, we could trial and see how it lands within primary care and also within the trust, and see in terms of the data that we get from that, how this can be then rolled out across the area if successful. So that the implementation approach just talks about the steps that we would take in order to get this pathway operational. So the final project I'm going to talk about is the Coding Improvement Project, which builds on the learning from Chalfont's PCN. And those of you who were in attendance at one of these meetings last year would have probably remembered a really great presentation by the Chalfont's PCN about a coding and data recording improvement initiative that they did across their PCN. And what we are wanting to do is roll this out across any other PCNs that may be interested in this. So it really aims to strengthen the data quality and improve coding consistency, because as we know, there's lots of differences in how we code and what is coded within primary care. And the aim is to enhance the accuracy of the patient identification for targeted prevention and early diagnosis. So as I've mentioned, we know that there's quite a lot of variation in coding and data recording across practices, and that's because we all do things slightly differently. And this is particularly present for kind of screening non-attendance, opt-out status and vaccination records. And often this is because there's lots of different codes that can be used. What the Chalfont's PCN did was a large-scale data cleansing that demonstrated that inaccurate or inconsistent coding can lead to inaccurate cohorts that were then targeted, which obviously if you're targeting the wrong cohort, then the ones that need to be targeted are not getting the prompts to come and have their screening done. And also it looked at the recall processes that we have and could cross-correlate with the uptake data. Now, what was really important was that we validate this with external data sets, which was great that Gemma's on the call, because she can talk more about those data sets within the screening team. And also it highlights the limitations of the coding data used alone and the importance of kind of standardizing high quality recording. So again, the next step would be for any interested PCNs to be identified by an expression of interest process, and we can use insights from the Chalfont PCN to shape the project model, because a lot of that hard work has already been done, which is really great when you're starting a project of this kind of size. So I don't know whether anyone has any questions, any clinical questions about those projects or anything else that they may want to raise at this point. Oh, Caitlin, have you got your hand up?
Yes, just a quick question. Did the kind of previous PCN use System 1, or was it EMIS based? Is that kind of looking at, again, with the coding around kind of the Ardens templates and things, or is that kind of a separate?
So I'm pretty sure they were an EMIS practice, but I don't know whether there's anyone from the Chalfont PCN on, because I'm aware that there's only 1 or 2 practices within the area that still use System 1.
Yeah, we're the opposite in kind of Swindon. It's mainly System 1 based in our area. So just thinking, yeah, that would be something we might just think about if we're kind of modelling data.
Yeah, no, that's a great point, actually. Yeah, I'm pretty sure it would have been an EMIS practice. So we can look at kind of how we can help with that, because exactly, you don't want to be spending lots of time creating searches and how to do that if we can help from an alliance point of view. Steph, were you going to say something on that?
Yeah, exactly that. So we absolutely want to make it equitable where possible. And I appreciate that. I think there's in the Thames Valley area, I think there's only 4 PCNs that use System 1. So, but we would work with Ardens and we would just make sure it was tailored for a System 1 approach.
Thank you. That's a great question. Any other questions? I think we're...
Sorry, I do have one more. Sorry.
Yeah, sure.
I was just going to ask as well, with the lung screening with the x-rays, is that also including kind of patients who already have a primary cancer of a different diagnosis, or is it just patients kind of symptomatic who have no cancer previous diagnosis or anything? Is it just based off?
So the project that was done in the East Midlands was based on symptomatic patients who, it was actually rolled out in what used to be a really high mining population. So they knew there was lots of high risk individuals.
Yeah.
So they were wanting to capture those people that were probably more hesitant to see the GP, even if they had symptoms, or smokers and felt, you know, well, I smoke, I've got a cough, that's how I've always been. So it was targeted to that population. There was some exclusion criteria, and you know, when you look at their project plan, you know, they're very careful to not do repeated chest x-rays in people that present every 6 months worried about. So it went through quite a thorough process. I don't know whether that answers your question.
That's great. That's helpful. Thank you.
Steph, are you ready to go through our fit data?
I will, but just before I move on to that, I guess for a little bit further context. So what we're hoping to do with these 3 projects is over the next month or so is to start working them up in earnest. We obviously we're still waiting to get our final approval from the plan that we've submitted to NHS England. So these are our aspirations for the year rather than our absolutes, but that doesn't mean we're not working in the background on them. We're having conversations with different clinical teams, and I would welcome anyone who's actually interested to just pop in the chat if you're interested in any of these, to start developing almost like the protocols behind them. We also then really need to understand what the potential cost implications are. Based on that, we will then be able to work out how many PCNs we might be able to invite to each in different phases. So we will use all of that information to then put out an expression of interest, and I appreciate that based on PCN sizes that there might have to be a range there as well. So yeah, I can see people putting in the chat, so that's great. Yeah, just keep us posted, and we'll update through this group as well how we're going. Do you want me to stay on for the fit stuff?
Yes,
so
please,
I get this is the lovely section. So yeah, just as we're at the end of April, I thought it'd be a really, really lovely way to finish the financial year and start the new one with a bit of a good news story. So what we've got here is some data that we get from the national team for basically looking at our fit levels. And what you can see on this slide is where we basically where we were. So the slide on the left hand side is April, and where we finished with the most recent data that we've received in February of this year. And for the last 7 months, Thames Valley has been consistently top of the southeast. So thank you everybody for your amazing work, for your commitment to this piece of work, and thank you to the internal team that have supported with developing resources and helping individual PCNs as they've requested it. If we go into the next slide, please. So I've just got, I thought, well, for some of you, you might be interested on your individual positions at a place level. So again, on the left-hand side, it's the April position, and on the right-hand side, the February position. And I've tried to pull out here each of the places that make up the whole Cancer Alliance. So at the top, we've got books, well, the old Bob, and at the bottom, we've got Frimley, and I've got the BSW bit for Swindon, because we only have a small part of BSW. But again, what you can see is that huge improvement. I particularly want to call out Oxford, who have done an amazing job as a place to get over the 80% consistently, and BSW as well. Next slide, please. And this one, so this is only Thames Valley, but we do have the same information, and it shows every practice. And I don't expect you to look at every practice, but what is really obvious on this slide is the change in that gap. So if you look at the dotted orange line at the top, how many practices were not meeting that threshold of 80%. And at the end, where we finished in February, how much that gap is reduced. And when you do look at the detail, you can see some of those practices that were missing at the end that don't have any data recorded at all. They're actually the ones that are much higher up on the endpoint in February. So just thought it was a very nice way to finish the year. And once again, thank you to everybody.
Thank you, Steph. And while you've been talking, quite a few people have popped in the chat that they're interested in the progress. So this is great news. What we will do is email you all directly and just find out which project in particular you're interested in, and get a bit more detail, and then let you know with any developments that we have moving forward. So thank you for that. That's really great. So I'm just going to hand over, if there's no questions about the fit data, to Andrew from CAHA, who's going to talk through a project that's going to be running about behavioural science. So Andrew, are you there?
Yeah, brilliant. Thanks, Katie. Can everyone hear me? Is it all clear? Yeah, great. Hi, everyone. So I'm Andrew. I'm a senior behavioural science consultant for a company called CAHA. And we're currently working with the Cancer Alliance and also NHSC on a bit of a broad ranging project really that kind of sits within the prevention and the screening priorities that KK was mentioning earlier, around how we can use behavioural science as an approach to increase uptake of breast cancer screening and also of HPV immunisations as well. So two different work streams within that. And we're just going to talk to you for kind of 10-15 minutes about what that looks like, I guess. So in terms of an overall overview of the project, as I mentioned, we're supporting NHSE and the Cancer Alliance around two distinct challenges, I guess, in terms of under-attendance at routine breast cancer screening appointments, and then also low uptake of HPV vaccinations in a secondary school setting as well. What we're really trying to do here is embed behavioural science to support the development of interventions that are specifically trying to influence decision making around health. So what we're starting to look at is how can we go above and beyond just education and information and start to really play on the levers of decision making that are influencing these behaviours within individuals across the region. So that's what we're really focusing on, and that'll be informed by localized insights. So surveys, interviews, focus groups, guided by different kind of models within behavioural science to really understand key barriers to cancer screening and also to vaccination as well. two different work streams, as I mentioned, but we're running them essentially simultaneously and both following this, what we tend to call a think big, start small principle, which is kind of in line with some of the stuff that's been spoken about already in terms of developing these interventions and testing them on a small scale first, with the plan being that if we can successfully evidence an impact, then these tools and these interventions can become more broadly available across the whole region to hopefully really shift the dial as a result of those initial trials. Next slide, please. Thank you. And then just as a kind of really high level introduction, because obviously I've mentioned behavioral science a couple of times and it might be a new topic or a new term for a few of you, so just wanted to give you kind of a flavour of what that is. As I mentioned, this is all about looking kind of beyond education and information to really what is influencing human habits, actions, intentions. So we're pulling from areas of research from psychology, economics, social policy, service redesign, anything that's influencing how we understand how people make decisions and why they make those decisions kind of falls within this umbrella term of behavioral science. And that's the kind of approach that we're looking to take here. Next slide, please. A big part that's come out of behavioral science research is this idea of nudge theory. So this is a real kind of applied field of research and how we can take that evidence from psychology and economics to really influence real world decision making. And nudges are the main kind of tool to do that in terms of finding a way to influence an individual to behave in a predictable way, but without reducing the choices that are available to them. So this is all about changing the environment in which choices are being made to ensure that the more positive choice is the best one available to that individual and they're more likely to take that. So if we take, for example, screening and we went ahead and mandated breast screening for everybody in the country, that wouldn't class as a nudge because that is removing that choice from those individuals. What we're trying to do here is maintain that freedom of choice, but make sure that attending the breast screening appointment is the easier and more positive and more attractive option for more people across the region. Next slide, please. And a really important thing to mention at this stage is that, as I've mentioned, we're not trying to take choice away from people here. There is obviously an ethical side to this as an applied field of research. We're trying to support and guide individuals to make choices that we believe are positive for themselves and or wider societies. This is all about key principles in terms of, yes, we're looking to influence behavior, but we're making sure that freedom of choice is maintained and we're influencing a kind of a more positive behavior and also being transparent in the way we do that. This isn't subliminal messaging or anything like that. This is just about slightly changing the environment in which these choices are made and tweaking the information that is being shared and how it's being shared as well. Next slide, please. So again, something I've touched on, but why we're taking this approach is all around the traditional approaches to influencing behavior, typically educating and informing people, giving them as much information as possible with the belief that people will then make a rational choice off the back of that. What we know from behavioral science research is that's not always necessarily the case. So what's almost more impactful on people's decision making is the context in which they're making that choice. So what's going on around them, the way the choice is framed. So you can say the same thing positively or negatively and get two different responses from it. Who's communicating the message? So is that message coming from someone that I trust or someone in a position of authority or someone that I relate to? And then also what other people are doing. If we see lots of other people engaging in a behavior, then we're more likely to do the same thing. So it's all about taking those slightly different approaches to complement the education and the information that's already out there. And this isn't an approach that we don't have evidence for. We've utilized these kinds of techniques in various different areas of the country on different kinds of projects and objectives and have successfully achieved big increases in uptake of various different programs. So adolescent immunization, we did a big project up in the northeast, not just focused on HPV, but the other ones as well, and averaged an 11% increase in uptake in the areas in which we were working. We've got tons of experience working on cervical screening uptake as well in that cancer screening space and have successfully increased uptake in Bedfordshire, Luton and Milton Keynes by 38%, again in the areas we were working. And then equally further down the pathway as well. So when people are referred into secondary care, how do we make sure that less people are DNAing those appointments? And again, we've worked on projects there where we've reduced missed appointments by 16.4%. So there's evidence for these approaches is what we're trying to get at there. For this project itself, obviously 2 different work streams working simultaneously. The HPV vaccination stream at the moment is slightly more urgent because what we're trying to do is evidence impact before this school year finishes so that we can look to scale up in the next school year. So we're working with 2 schools at the moment who have vaccination dates within the next 4 to 6 weeks. So that's a little bit more urgent at this point. Whereas for the breast screening timeline, it's slightly more extended because what we're looking to do is identify kind of practices and PCNs who have their breast screening rounds within kind of late 2026 and early 2027, just to allow a little bit more time in terms of the insights gathering, intervention development, and being able to test that again with recommendations for the future moving forward. So 2 projects at slightly different stages, but equally kind of extending them across the next 12 to 18 months with that scale up included. Next slide, please. In terms of progress today, obviously most of the work that we've done so far is around that kind of insights and context building. We've been doing a lot of work with our predictive analytics capability where we can pull from various different publicly available data sets to map certain indicators that are closely associated with uptake of breast screening or HPV vaccination, and from those indicators and those kind of demographic factors predict where lower uptake regions might be in the future. So what we've been able to do is run that kind of analysis across the region to help identify our trial areas to begin with. And for both HPV and breast, it's looking like Slough is the area in which we are going to hopefully achieve the most impact to begin with. And if we can evidence something successful in that Slough region, that's when it can become available broader and wider. So again, to support that, we've done engagement with local providers, context building activities with other stakeholders as well. And for the HPV workstream in particular, we've already commenced that kind of insights gathering piece, working closely with schools, councils, and the immunisation provider to make sure that we really can uncover those key barriers that we need to address. And next slide, please. Finally, just in terms of next steps, just to make sure that we can continue that delivery of this project in a timely manner. What we're hoping to get here is in terms of working with screening providers to really understand that process and opportunities to influence, which we're getting to a good point with now for that HPV work, but also for breast screening as well, so that we can fully understand kind of where we need to have that impact and where those chances are where we can influence behaviour. Engaging with relevant partners as well, obviously, to make sure that this is joined up and sustainable as much as possible. It's not just focusing on one area and making something specific to there. We're trying to get something that is generalizable across the patch. Gathering insights from the local community, as I mentioned, to really uncover those barriers. So how can we extend that reach and make sure we're speaking to as many people as possible? And then when we get to that intervention development piece, making sure that that's co-designed and that the right people are involved to make sure, again, it's appropriate, it's applicable, and also clinically accurate as well, which is hopefully where we can get some support there. And then obviously in terms of actually implementing those interventions, identifying the right kinds of the PCNs, GP practices that can support in terms of implementing those interventions for those breast screening rounds, and obviously working closely with the providers to support that as well, where we then will look to scale up across the patch following those trials, which hopefully will be bringing the successes that we're looking for so that we've got that evidence base moving forwards. Appreciate I've flown through that. Have we got any time for any questions, or is that all okay?
No, that's great. Thank you so much, Andrew. It's a really exciting project, and I know that you had quite a tight timeline to go. There is a couple of questions in the chat. I don't know. Shall I read them out? Or Caitlin, do you want to say your question? It might be easier that way.
Sorry, yes, me again. I was just wondering, Andrew, is the targets for HPV, are you dividing it by gender, or is it a combined effort you're looking at?
So it's a combined effort at the moment, but we're fully aware of, especially in the schools that we've identified, male uptake is lower than female at the moment. Obviously, since that shift to both kind of males and females being offered the vaccine, we're also looking to understand why that is. So anything that we develop will be trying to kind of reduce that gap at the same time.
Cool. And is the resource kind of focusing on that kind of cervical cancer elimination? Is that kind of the messaging behind it, or is it looking at kind of both cancer risks for both genders in that sense too?
So again, we're waiting on the insights to come back in terms of what the key kind of drivers and barriers are to uptake. what we're anticipating is that there is quite a strong connection to cervical cancer and also to sexual activity, which might actually be a barrier for some populations. So instinctively, I would imagine the messaging will also be referencing the other types of cancer that it can protect against. But we can't really say that for sure until we've understood exactly what it is that's preventing parents from giving their consent, I think.
Right.
Thank you. Heather, do you want to come in?
Yeah, just on that point, yeah, it's I'm just kind of supporting what Andrew's saying, really. The fact that I think historically there was the link between get the HPV vaccine for cervical cancer kind of protection. And so that did seem to exclude the males. So making sure it's kind of, I guess, more of a broader target rather than just focus on girls and women. That's the message that's we've got from school, and that I suppose that's what the national message is as well at the moment, broaden it to include males and females.
Thank you, that's really helpful. Is there any more questions for Andrew or our screening and MIMS team as we've got them on the call?
I can always put my email address in the chat as well. So if anyone does have any questions or anything like that beyond the meeting, you'll have my contact details from there.
That'd be super helpful. Thank you. Brilliant. So I think if there's no more questions, we'll move on to the next presentation. Is Simon here? I can't see. Sorry, my screen went.
Yeah, just arrived. I'm going to turn my video off because I've got something going on with bandwidth at the moment, but I am here. Okay.
Brilliant. Thank you.
Super duper.
KK, are you able to move the slideshow down, please? Still here.
Yeah, can you see the slides?
Yeah, they're just not moving, that's all. They're just stuck on the last slide of Andrew's.
Oh, I've actually moved it. I have to just stop sharing quickly and then look at that. Just a moment, please.
Sorry, just bear with us.
I'm very happy to
Yes.
present it from this end, get the slides up. Yeah.
Can you see it now?
If it works. No.
Can you see that, Simon?
Yes, there it is. Okay.
Oh, brilliant. Thank you.
Okay.
Right. So in terms of introducing myself, my name's Simon Tarrant. I work for Thames Valley ICB. I was working for Bob ICB when we undertook this project. My job title is Autism and Crisis Care Pathway Development Manager, and I do a lot of work on the side around reasonable adjustment. So could we have the next slide, please? Right, and what I'm here to do is basically we've been working with a couple of your colleagues, Abby and Coyote. We were asked to look at what could reasonable adjustments look like within cancer screening pathways. So I'm here to present what our thinking is to date. I'm going to present the recommendation, and then I think we need to think about next steps in terms of whether this is adopted or not. So could we have the next slide, please? So the product methodology, I'll skip through this very quickly, but we did have co-production with a very small group of people with lived experience, and this was obviously autistic women. We also had a consultation with our GP clinical lead to look at how practical some of these recommendations would be. We also undertook a literature review to support the work, and so I have undertaken work in other areas. So there's some pulling through of learning from other projects that I've been involved in. Could I have the next slide, please? Okay, so we had a look at the data that we had available on connected care. I know it's quite limited in terms of what we were able to access. I think it was bowel, cervical cancer, and I can't remember the other one that was available. When we had a look, we saw there's quite a big discrepancy in cervical smear testing. We see almost double the rate of autistic women that are not attending. And I think, again, within the general population of 9% of people not attending, I would also raise that we've got underdiagnosis in autistic females. So again, I think there's going to be autistic females and probably other forms of neurodiversity within that 9%. So that 18% figure is quite likely to be a lot higher. But we are seeing double the rate of did not attend in this population of people. Could I have the next slide, please? Okay, so and discussions with our experts by experience. And I think the other thing to pull through is if you look at the themes around barriers to healthcare for autistic people, these are the themes that surround the sort of sensory environments that people are exposed to that are often quite hostile for people who have a very sort of sensitive sensory experience. You've got communication barriers between the different communication styles between autism and the sort of neurotypical people that they're often meeting. We've got these environmental factors such as busy waiting rooms, a lot of unpredictability as well that autistic people find difficult. So the barriers that are present in cervical smear testing, we've got finer detail around what those actually look like for within cervical smear testing, but they're themes that pull through in every area of healthcare. And ultimately, these barriers, if you think of the autistic processing or the way that information is processed, they actually combine to create huge levels of anxiety. So it's either going to be anxiety during the appointment, or we see a lot of pre-appointment anxiety, which often results in people not attending. And I think the other thing, again, that was put in through from my experience is previous past experiences, and the fact that they haven't had adjustments made actually means they're less likely to attend in the future. So there's something about getting it right early on for people in this pathway. Can I have the next slide, please? Okay. So between us all, we drafted 3 passports. Now we've got a neuro inclusion passport, which has been used across our mental health system very successfully. And indeed, it's now attracted national attention. Basically, it's geared around understanding the factors that cause autistic anxiety, and we're proactively trying to manage those through that passport in terms of adjustments. It really is geared towards appointments, and it breaks down the whole appointment pathway from what happens before an appointment in terms of the contact that's made, the information that's provided, adjustments during an actual appointment, and then what happens after the appointment. So it's a really, it's a really full document, but there's some quite complex stages within it. So, and the stages really relate to the fact that it needs to be embedded into an electronic patient record, it needs to be located, it needs to be read, and it needs to be acted upon. So within that, the sort of failure is built into it to some extent. We then developed a very shorter form of the passport that was really focused around the actual appointment itself. And what we wanted to do was we were considering how do we bypass the electronic patient record glitches in terms of it being located and read. We've also got glitches in terms of coding. If we're coding and targeting coded people, we could not by that. The idea with this one is really to have something that you could put under somebody's nose right at the start of the appointment or as you go to reception. So it's putting a lot of power back to the actual patient itself. And again, if you think about autism and the sort of communication differences that often act as barriers, this is reducing that need to have that communication in the moment. Okay, so you can come with a little list of things that we could potentially be doing differently. And again, what we really liked about the simple form passport is we're putting control back to the patient as long as they can access it easily, and it's immediate. There's no need for a clinician to locate it through a electronic patient record and then act on it. So it really is putting information and control back to the patient. And yes, I've talked ahead of that one. So yeah, again, we found this in some of the other pilots we've done. It actually works as a two-way communication tool. It's going to lower anxiety in the moment by taking away some of that processing need around the communication and explaining yourself. And again, what the experts by experience were telling us was, if we could target this into that first cervical smear testing, in effect, the patient could be co-producing their care plan, working out what works well for them. And it also empowers the patient to some extent. Again, there's some, we're limited around some of the sensory changes we can make in environments. So again, we're putting that back to the patient in terms of liberating them to bring whatever makes them comfortable. Can I have the next slide, please? So in terms of adopting it, and we still don't quite know where we need to pin this, and I guess this is part of the outcome from this. So it needs to be really easy for a patient to access. So could it be something that's linked to an appointment letter? Could it be something that's sent out in terms of an information leaflet? Could it be something that's on a web page that's downloadable? Not linking it to an electronic patient record. So we're not looking at diagnostic criteria. We're not looking at something that needs to be located and acted upon with an alert. And we found that to be quite a challenge. Based on the work we've done with dentistry very recently, we would also recommend that this goes out, if it's adopted, as a universal offer. Again, we're bypassing the coding and the undiagnosed challenges. We're normalizing what that adjustment offer is. And if you're designing adjustments with autism in mind, other groups of need benefit, and we found it in other pilots that universal offer is being adopted by not only the people we targeted for, but people who have anxiety, PTSD, etc., or learning disabilities. And again, our experts by experience were saying, if we could get this in, those really early cervical smear tests, we've got an opportunity to actually co-produce a care plan that is going to be a work for the patient going forward, and hopefully make it more likely for them to come back. Could I have the next slide, please? I had to put this out there because I've been working with experts by experience. We've got to pull that voice through. But again, we need to recognise that if home testing kits are available in this area, that is likely to significantly increase the uptake of cervical smear testing in autistic women, because it's basically taking out most of the barriers that we see in terms of attending clinics, communication, the environment, etc. So again, we just promised our EBEs that we would put this forward. Could I have the next slide? Right, I think I've covered this already. So what we have found with other passport projects is this is something that is scalable. We've got transferable methodology, so we can lift the methodology into different areas. And if you were to look at different areas of cancer screening, there's a methodology that we can lift and shift. The way that we're advocating it's used is actually low burden for clinicians, and there's actually no cost around it at all. This is about culture and wanting to do things differently for people. So there's no additional funding needed around the actual delivery or making this passport available. Could I have the next slide? Right, I just want to touch on this very quickly. We've just had a really successful project in community dentistry, which is the dental services that people access if they can't access high street dentistry due to high anxiety, uncooperation, not being able to cooperate with treatment, etc. Now, dentistry has a way of delivering this passport as part of a bundle of forms. We do it as part of the new patient registration process. Again, it goes out as a universal offer and people opt in. The people opting into it are autistic, learning disabled, people with anxiety, people with PTSD. And the outcomes we've had in terms of the evaluation have actually been quite startling. So we know that for patients, it's making the dental experience better. It's all reducing appointment anxiety. And for staff, again, they're seeing the benefits in terms of having more detail around the actual patient and their needs, an idea of what to do differently. And what, again, we're finding there is it's improving their ability to deliver an appointment successfully to the patient in front of them. And I think that was my last slide. And I think Coyote and Abby were maybe going to come in at this point.
Thanks, Simon.
Okay.
I think Coyote, yeah, back to you.
No, thank you so much. At least thanks for the presentation. I don't know if anyone have any question, but
Heather, have you got a question?
Yeah, more a comment really. I suppose on the very first slide, and I'm sure the primary care colleagues would kind of agree that 91% uptake of cervical screening in the general population just isn't the case. And I suppose in Bob it's more like 60%. Yes, the difference between neurodiversion and the general population is well documented, and some of the local data I've got is about maybe 10 or even more, at least 10% difference. But yeah, so I think that's the first thing. The data, I think, is if it's from connected care, then that might be the reason why it's might not be completely accurate. But the issue still exists, so that's the thing. And then you also mentioned about tagging it onto EPR, but I suppose it wouldn't be, you wouldn't be finding these women via EPR, would you? I suppose it would be more kind of the primary care systems.
I think
EMIS,
the EPR is a red herring, to be honest, Heather. As I say, if at that point you're missing need in terms of people who are undiagnosed or sat on waiting lists, and we know we've got a crisis, particularly in the diagnosis and recognition of autistic women. And at that point, you then need to start thinking of different processes, don't you? So you're going to then have a process for people who aren't autistic and people who are autistic. And again, I think that at the minute we start having those sort of branches off of a process, we're beginning to build failure in, which is why we're advocating that universal offer. And the fact that if we can make it easy for people to access, we put control back to the patient.
And I know that we've had a discussion about this project, about how it might be delivered in primary care. And I suppose, I don't know if you've had any further thoughts on that, Abby.
So thanks, Eda. Coyote was just going to come in to describe kind of like the next steps for this. I know I think we've only got 5 minutes, haven't we? So Coyote was going to describe the next steps, but I'm sure there might be a few other questions that need to be taken outside of the meeting. But I can see that Amber's got a hand up. Coyote, maybe Amber can ask a question and then you can describe our next steps.
Yeah, it was just a little point of clarity. So there was a mention of the self-testing, and we're not quite there yet within the NHS. So it was just a point of clarity there. It's definitely coming for non-responders, but it's not quite implemented.
We know, like Simon said, Simon's kind of like a pet project, and it's like, I have to put that out there. But
absolutely.
We recognize that.
It's definitely coming, but we're not quite there yet.
We're not considering it as part of this project, but like Simon says, it's his dream or wish list. So he had to mention it.
No, that's fine. That's fine. Thank you.
I think no more questions. So, of course, as mentioned during the presentation, we are trying to work out where to plug that in the system. And then what we are trying to do, of course, is to move to the piloting phase. And then we're trying to look at how this could work within the system and then see lessons that could be learned and then improve on how it can be adopted on a wider scale. So the whole idea is to put communication out at some point to everyone where primary care that will be interested would indicate, and then would see how we could pilot with them. And then at the moment, we are still working on the funding model on how to approach this. So all this will be detailed in the subsequent email that will be going around. But at least the presentation idea today is to socialize this and then let everyone know where we are at and then the next phase. So the next phase will be getting at everyone, detailing more on what we'll be doing, the funding model, and see how we could at least pilot on some selected sites.
Yeah. Thank you. That's great. So I think if there is any questions, I'm sure Coyote, Abby, and Simon will take any of those outside of the meeting. But that was really useful. Thank you all for that presentation. Just in the last couple of minutes, we've just got time. Steph, do you want to go through the governance in terms of reference, and then we'll finish up for today?
Yeah, thank you. So really this is, again, it's that new year and kind of just reframing how we do things. So we'll circulate this so you've got an opportunity to digest it properly outside of the meeting. But what we'd like to do is, I guess, make it less of a one-sided meeting where we give lots of information and actually use the clinical and non-clinical expertise that you all bring to kind of drive forward as a reference group, and just use it as an opportunity to discuss and strategize our kind of direction of travel going forward. So I've just described the kind of proposed purpose and remit of the group in the top section. So again, using this group as an expert advisory group, supporting transformation across the system, strengthening the relationship between primary secondary care, and making sure that we're sharing best practice whilst reducing duplication where possible. We've got our GP clinical lead as chair, and we've got Kajal, our co-chair, who will be alternating. Meetings take place this time every month. Agendas papers will go out within 3 days before the meeting, and then we'll follow up within 5. And then we will report via the Alliance programme meeting, but also by exception up to our executive board as well. Not expecting anyone to comment at this point. This is the first time you're seeing it, but what we'll do is share this, and then hopefully if you've got any queries or clarifications, please do respond via email, and then we'll aim to get this signed off at the next meeting.
Thank you, Steph. That's great. And also this just some education updates and resources, but we will send those out as well. So I suppose I just want to thank the presenters from today. I think it's been a really interesting update, and to everyone that's attended, because we do appreciate primary care is very busy. There's lots of pressures within the system. So thank you for all joining and all your input throughout the afternoon, and we look forward to seeing you next month.